Hello everyone, welcome to another episode of Next Savior Essential Question Series for NEET PG 2025, Part 9 Medicine. Today we are going to discuss a very important topic which is almost every year kept in your examination related to a spondyloarthropathy, that is ankylosing spondylitis. You see, here we are not going to exactly talk about the ankylosing spondylitis. You know very well about the findings on the basis of which, or the X-ray findings on the basis of which you will mark the answer. But how the other differentials are kept in the option, and if this time the examiner decides not to you to mark the answer of ankylosing, then how will you lead to the options like port spine, disc syndrome, or degenerative disc disease as the answer? Because if he changes the term to loss of weight or appetite, then the answer might not become ankylosing spondylitis. If he changes the term to anterior syndesmophytes on the X-ray findings, then the answer might become disc syndrome. If he changes the term to the radicular pain, which improves with rest, then the answer might become the degenerative disc disease. So this is exactly what we have to find out by keeping a prototype question on ankylosing spondylitis. Now, first of all, if we read the question like how it is presented to you in every examination, a 30-year-old age is extremely important because for young individuals, it could be tuberculosis or ankylosing spondylitis, but for older individuals, it could be degenerative or disc syndrome. Male, the gender is extremely important because ankylosing spondylitis is predominantly found in males, presents with chronic back pain that gradually worsened over 5 years. The pain is worse in the morning and improves with activity. And when you see this line in particular, then the answer for your question, obviously, but just by reading the first line, then you can conclude to the answer. The answer for that question is ankylosing spondylitis. But as I told you, we are not here to discuss the topic ankylosing. We are here to discuss the other topics and how to differentiate it from the other differentials which are always provided to you in the question. And it is associated with the stiffness lasting for more than 1 hour. He denies any history of trauma. There is no weight loss. There is no radicular pain. Over the past year, he has noticed difficulty in fully expanding his chest. There will be limitation of chest expansion. As you know, inspiratory chest expansion can lead all the way up to increase in the 7 centimeters. It is limited. And an occasional dull ache in the hips and buttocks. All right. On examination, there is a reduced spine mobility. On forward bending, the shoulders is found to be less than 5 centimeters because 5 is normal. Tenderness over sacroiliac joints. You see, there is no question which is complete for ankylosing spondylitis if sacroiliac joint is not given. If SI joint is not given in the question, think twice before marking the answer of ankylosing spondylitis because it is considered to be a hallmark feature. Remember one thing, a radiological feature where sacroiliitis is given along with one of the clinical feature according to modified New York criteria, then answer for the ankylosing spondylitis is certain. Right? Chest expansion, as I told you, is limited to 2 centimeters. That means it is less than 5 or 7 centimeters, which is normal. As far as laboratory investigations are concerned, RA factor would never be provided to you because it is insignificant. It is RA negative spondyloarthropathy. So ESR is found to be elevated. CRP in any inflammatory condition is found to be elevated. HLA-B27 positivity is identified in 90% of the cases, but it is not a foolproof diagnostic criteria. And CBC is absolutely normal. Why the CBC is important to be provided in the question? Because had it been tuberculosis, then the leukocyte count would have been increased. Based on this question, as you have very easily identified that the answer for this question is ankylosing spondylitis. Why? Because of the chronic back pain, which improves with exercises. Sacroiliitis, which is a hallmark feature, as I told you, according to the modified New York criteria, if it is present along with one of the clinical feature, then the answer is certain. HLA-B27 positivity in 90% of the cases, restricted spine mobility, and limited chest expansion. So you are certain that the answer for this question is ankylosing spondylitis. But as I told you, we are not here to discuss the ankylosing. We are here to discuss the other options and why to rule those other options out. Now, the first one is DISH syndrome. It is diffuse idiopathic skeletal hyperostosis. And how this thing is identified, if these vertebral bodies are visualized in the lateral view, and in between these vertebral bodies, if the anterior spinal ligament, the anterior longitudinal ligament, gets calcified in four or more continuous vertebral bodies, then the answer for that question is certain. So, how these things are different? You see, in this syndrome, the age is more in comparison to the ankylosing spondylitis. The sacroiliitis is typically absent, but it is typically present in ankylosing. In this syndrome, the syndesmophytes are thick, they are non-marginal, they are flowing ossifications, which you will see in the X-rays. As far as chest expansion and HLA-B27 are concerned, there is no positive finding. So, diffuse idiopathic skeletal hyperostosis is basically distinguished on the basis of the X-rays. And when we will discuss the X-ray, you will come to know what are the two important findings on the basis of which you will mark the answer for this syndrome. Then the next one obviously is the Potts spine, because this is what we are thinking, that this time, if such a question comes and the examiner decides not to give ankylosing as the answer, then these are the clinical findings which will be provided to you in case of a question related to Potts spine. There will be a localized, constant, and progressive pain in the back. And there are some characteristics associated with this pain, like the patient awakes at night because of this pain. The pain is extreme at night in earlier of the stages, and it might also result in neurological compromise because of the compression of the spinal cord or the nerves. Now, there will be associated fever, there will be weight loss, and the night sweats. These are the constitutional symptoms which will always be provided to you. As far as the spinal involvement is concerned, yes, thoracic or lumbar, it might involve both of them. Even lumbar tuberculosis is far, far common today. X-ray findings, you will see when we are going to have a discussion on the X-rays that how it is a single level spondylodiscitis in comparison to the bamboo spine or the marginal syndesmophytes which are visualized in case of ankylosing spondylitis. Now, ESR, CRP are extremely high, and when you go for the laboratory markers, the Montauk text is found to be positive, the TB Gold is found to be positive, and MRI is mandatory in order to look for the abscess, look for the destruction, look for the edema in the bone, look for the compression of the nerves. So MRI is extremely important, right? So this is how we are going to distinguish on the basis of these clinical features, which will always be provided to you for Potts spine. Now, just imagine, like in case of ankylosing spondylitis, what they used to give is pain in the sacroiliac joint or low back pain, which improves with activity. But in case of Potts spine, what they will say, they will give you fever, they will give you a history of weight loss, they will give you a history of night sweats, and then they will give you a history of localized, constant, progressive pain, which is more at night. And there could be also an involvement of neurological feature in the form of weakness, loss of sensations, inability to walk with or without support. So these are the findings which could be provided in a question related to Potts spine, that is tuberculosis of the spine. And finally, as far as degenerative disc disease is concerned, one thing is very usual for you to identify is the age, because it is a degenerative condition, so it has to be higher age. And as far as pain characteristics are concerned, it is mechanical pain. That means it gets worsened with activity, but it improves with rest. As far as other features are concerned, it is of not much use, but this is how, yes, there will be no history of weight loss, there will be no history of constitutional features. In case of degenerative disc disease, the age will be higher, there will be a gradual increase in the pain, and the pain has to be mechanical. So this is how you are going to distinguish it with ankylosing spondylitis. Now, the second thing that they will provide you, or they might provide you, are the X-rays. And what are the positive X-ray findings on the basis of which you will confirm that the patient is suffering from ankylosing spondylitis? Are the fusion of the sacroiliac joints. You see, there will be a fusion of the sacroiliac joint. That is one most important finding. So these are the findings which you can see. Bilateral sacroiliitis, joint space narrowing, sclerosis, or the erosions, and these are considered to be the first X-ray findings, which are very clearly evident. The sacroiliac joints are fused. Apart from this, there will be syndesmophytes, that is thin marginal outgrowth. This is the marginal outgrowth along the vertebral bodies, and it is because of the calcification of the intervertebral disc. Then, as far as this term bamboo spine is concerned, it is purely theoretical. But how does it appear? There will be a fusion of the vertebral bodies due to ossification of the anterior and posterior longitudinal ligament. So it looks like a bone in continuity. all right, without any gap because of the calcification of these ligaments. Now, another thing that you can identify is the squaring of vertebrae. Now, what do you mean by the term squaring of vertebrae? You see, normally the vertebrae are biconcave. This is how the vertebrae looks like. But in this case of ankylosing spondylitis, they usually there is a usual loss of this biconcavity. It appears squared. It appears straighter as far as boundaries are concerned. So this is the squaring of the vertebrae, which is also apparent. Now, one of the theoretical sign is a dagger sign. Dagger sign basically is nothing but the it is the calcification of the interspinous ligament. You know, here there is an interspinous ligament, and if it gets fused, it will appear like a dagger on the X-ray. So majority of the time, this finding is also theoretical, but in one of the NEET PG examination, they gave you this X-ray where dagger sign was apparent. And in later stages there is going to be a scoliotic and kyphotic findings. Scoliosis or kyphotic means degenerative findings which results in the lateral or the posterior bending of the or curvatural abnormalities of the vertebrae. So these are the typical findings of the ankylosing spondylitis. Now, how to compare it with Pott's spine? Because how will you identify the X-ray of the tuberculosis of the spine? You see, in case of tuberculosis of the spine, there will be a single level spondylodiscitis. You know, the most common type of the Pott's spine is paradiscal. This is something that you already are aware of. Para means adjacent to, discal means intervertebral disc. So imagine if this is the intervertebral disc and the adjacent vertebral bodies which are getting affected by tuberculosis, so there will be reduction of the disc space. And because of this reduction of the disc space, this is how the vertebral body will appear like. There will be a destruction of the vertebrae, reduction of the disc space, and apparently over a period of time, they seems to be like fusing with each other. So this is how a single level spondylodiscitis, a very obvious finding on the basis of which you will identify that the patient probably is suffering from the Pott's spine, combining it with the clinical features that you have already read. Now, how to differentiate it with DISH syndrome? As I told you, that DISH syndrome distinguishing features are provided in the X-rays. Means you are going to distinguish it with ankylosing spondylitis by the findings on the X-ray. So one of the finding on the X-ray is the flowing ossification of the anterior longitudinal ligament. And you know, this is thick, continuous bony bridges which is spanning for more than 4 contiguous vertebrae. So it is diagnostic of this syndrome if it is provided in the age of more than 40, 45, 50, 55 years of age. So most common site to be affected is the thoracic spine. And second is the candle wax dripping sign, which is irregular, thick, flowing ossification along the anterior vertebral bodies, which is resembling the melted wax. It is nothing but the same finding, which we have discussed above, right? Like this. So this is known as candle wax dripping sign. So on the basis of the X-rays, you have to distinguish it with the ankylosing spondylitis. You remember the full form of DISH syndrome is diffuse idiopathic skeletal hyperostosis. And finally, the degenerative disc disease. You know, degenerative disc disease, majority of the times in the NEET PG question, the X-rays provided to you are those of spondylolisthesis. Spondylolisthesis. You know what is spondylolysis? It is a break in pars interarticularis. What is listhesis? When that break in pars interarticularis is responsible for separation of the vertebrae over the other. So there will be a separation of the vertebrae. As you see, there is a displacement of the vertebrae over the other. So that is a spondylolisthesis. So this question of spondylolisthesis will always be provided to you with the X-ray finding, along with the neurological compromise finding, along with the nerve compression finding. Like there will be a compression of the nerve root S1, there will be compression of the nerve root SL5, and both these two findings could also be provided to you in the question, along with the features of the mechanical pain. So this is how you are going to distinguish these four differentials which are always kept in a question related to ankylosing spondylitis. Now, if you go back to the question, you can very easily identify whatever we have discussed and how they are different from tuberculosis. You see, 30-year-old, so you can rule out the spondylolisthesis, you can rule out the disc syndrome. Male, it is more pointing towards the ankylosing spondylitis, chronic back pain gradually worsening over the past. The pain is worse in the morning, improves with activity. It is a specific finding for ankylosing. Is associated with this stiffness lasting for more than 1 hour. It could be a feature of tuberculosis also. But he denies any history of trauma, weight loss, or radicular pain. So this is how the tuberculosis and this degenerative disc disease can be ruled out. And then there are findings which are specifically pointing towards the ankylosing spondylitis, like there will be limited chest expansion, there will be reduced lumbar spine mobility, there will be tenderness over the sacroiliac joint, HLA-B27 positivity. So this is how you will identify it. It's very simple now. Answer for that question is ankylosing spondylitis. But you see, for the last 2 years, you are not only getting these features of ankylosing spondylitis, there are some specific hints also which are provided to you, and those specific hints are provided in the form of the extra-articular feature of ankylosing spondylitis. Now, if you break this term, ankylosing means the ankylosis, that is pathological fusion. Spond is the word which is used for axial skeleton. Itis is the word which is used for inflammation. So ankylosing spondylitis means it is the inflammatory pathology that results in the fusion of the axial skeleton. What are the extra articular features of the ankylosing spondylitis which are provided? Like if you remember, red eyes were given in the question, right? In 2023, I suppose. In 2022 also, there was a question on the red eye along with all the other features of ankylosing spondylitis. So as you know, that acute anterior uveitis is the most common extra-articular manifestation, which is unilateral, presenting with the painful red eye, photophobia, blurred vision, increased lacrimation, recurrent episodes. So these are the things which could be provided to you in the question. Apart from this, the cataract, glaucoma, and the cardiovascular symptoms in the form of aortic regurgitation, aortic valvular insufficiency, the third degree heart block, and the pulmonary involvement in the form of apical pulmonary fibrosis, which is although rare, a late feature. Then some of the features like prostatitis, the Budd's disease, the inflammatory bowel disease, which is always, it is very, very commonly present, and even the psoriasis. So these are the extra articular features of the ankylosing spondylitis that you have to remember. One more thing that you have to remember is enthesitis. It is the calcification of the tendons which are getting attached onto the bone. So some of the times the question related to ankylosing spondylitis along with the other features might also be presented with the heel pain because of this enthesitis, which is calcification of the tendons at the site of attachment to the bone. And one more thing that you should be knowing, because this question is very, very frequently asked, so you should also be knowing about the management of ankylosing spondylitis. You see, as far as the treatment is concerned, the treatment focuses on reducing the pain and improving the mobility. So, in order to improve the mobility, why? Because to prevent the structural damage from happening. So, management basically it involves the combination of the pharmacological, physical therapy, and lastly, the surgical interventions, if at all required. So, what is the first line of the management, which is very, very frequently kept or might be kept in your examination? So the mainstay of the treatment remains the anti-inflammatory drugs, and indomethacin is considered to be most preferred one in ankylosing spondylitis. Like otherwise, diclofenac, ibuprofen, naproxen can also be given, but COX-2 inhibitor like celecoxib, etoricoxib, they are safe because of GI tolerability. But indomethacin is considered to be the preferred drug in this case. Other drug that can also be provided if there is a failure, like for example, if there is a persistent disease despite giving you the non-steroidal anti-inflammatory drugs for more than 4 weeks, more than or equal to 4 weeks, and if there is a severe axial symptoms, there is peripheral arthritis also or extra-articular involvement, then in that case you can consider the disease-modifying drugs, that is TNF alpha inhibitors, and like infliximab, the adalimumab, the etanercept, the certolizumab. These are the drugs which can be given for ankylosing spondylitis. Now, these are the first line biologics for ankylosing. They are responsible for reducing the inflammation and halt the radiographic progression. But one thing that you have to be careful, that you have to screen the patient for tuberculosis because it might result in the suppression, immunosuppression. So first screen the patient for tuberculosis or any immunosuppressive condition, that after that only you decide to give the disease modifying therapy. Now, there is another set of drugs that can also be given, and that is interleukin 17 inhibitors. Now, what are the indications? Like TNF alpha failure. If this TNF alpha inhibitors, if they are failed or they are contraindicated, And another indication that these are better for the patients with concurrent psoriasis. So the drugs which can be used are secukinumab and ixekizumab. In case of rheumatoid arthritis, where the conventional disease-modifying anti-rheumatic drugs are used, so here it is only used for peripheral arteritis, and the drugs which can be used are sulfasalazine for peripheral arteritis, but not. It is of no use for axial disease, spondyloarthropathy. And methotrexate has got limited benefit in ankylosing spondylitis. Most importantly is the physiotherapy and lifestyle modification. Exercise is the cornerstone of ankylosing spondylitis management. Daily stretching, swimming is considered to be the best exercise. As a doctor, you can advise that swimming is the best exercise for the patient who is suffering in the initial stages of ankylosing spondylitis in order to uh, prevent the structural deformities from happening, and postural training in order to prevent the kyphosis. Lifestyle modification like weight loss, cessation of the smoking, and prone position, because prone position sleeping is helpful in preventing from the kyphosis, right? As far as corticosteroids are considered, it has a very limited role, and surgery obviously for refractory cases where there is a spinal deformity that requires correction, or hip involvement which might require the total hip replacement. So this is the profile for the management of the patient who is suffering from ankylosing spondylitis. As far as NEET PG students are concerned, you should be focusing on the first line management, the newer drugs, and physiotherapy, which is extremely, extremely important. Hope you have found the session helpful. Remember, this is one question which is always, always kept in your examination. And the motive of discussion of this question is not to discuss about ankylosing spondylitis. You already know many of the things related to this one. The motive was that what if the examiner this time decides not to give the ankylosing spondylitis as the answer? He decides Potts spine, degenerative, or Dish syndrome as a answer this time. All the best for your future examination. Stay happy, stay blessed, stay focused, and follow our Telegram in order not to miss any update related to this NEET PG 2025 examinations.